Okay, so welcome again to another Houston Methodist Renal Grand Rounds. I'm very happy to have Dr. Harish Seethapathy with us today from Massachusetts General Hospital. Just a brief intro about him. He did his medical degree at Madras Medical College. He did his residency at Rochester General Hospital and fellowship at Brigham and Women's Hospital in nephrology, where he is now a nephrologist at Massachusetts General and faculty at Harvard Medical School. He has a special interest in the care of patients with kidney disease and cancer, so onconephrology, and as we can expect, hyponatremia is a common occurrence. So he's done a lot of work recently on this topic, and he's also one of the program directors for the GlomCon, the International GlomCon Fellowship. So I'm very privileged to have him here with us to share his expertise. Dr. Seethapathy, thank you for your time, and please go ahead. We're looking forward to your talk today.
Thank you so much, Shane, and welcome everyone. It's such a privilege to have you as an audience today. And we're going to talk about the history of correction rates. And I'm a big student of history when it comes to certain topics. And I think this is one of the more fascinating topics in nephrology. So we'll go through some of the history with correction rates today. So first things first, I don't really have any disclosures related to the topic. And whenever we present a topic, I have to say, you have to ask the question, what is this talk really about? And in my own way, I think this is a no holds barred, detailed look at the evidence behind correction rates in severe hyponatremia. It's basically about how did we get here and what data got us here and why do we practice the way we do. And especially with this particular topic, I think there's a lot of controversy, bias, polarization in the way that people talk about this. So when I do describe the studies, I've done my best to sort of give you the conclusions in the author's own words and not put my own opinion into it. Of course, we have to interpret those studies. But at the same time, I think it's important to sort of know about what the authors thought at the time that they published these studies, because many of them are historical, they're from decades ago. Unlike many areas of nephrology, where there's usually a diversity of voices, I think in this particular topic, there's two very strong camps. These are scientists who are like super smart, way above my pay grade, people that we sort of get inspired by, but their voices were very distinct in shaping this discourse. So I'm not going to use real names here because it's not one particular person, it's probably like a group of people. So I'm going to go off one of my favorite shows and name them Stark and Targaryen. And Stark for slow correction or ice, or fire for fast correction or Targaryen. Like the show itself, I don't think this topic has a particularly great ending. But I do think there's a lot of fascinating things that happen till we get to the point of now. So what does House of Stark believe? They believe that everybody should be corrected slowly, as there is high risk and no benefit to fast correction. House of Targaryen, on the other hand, believes that there is no risk to fast correction as long as the sodium is not corrected to normal or mildly hyponatremic levels. So as long as you keep the sodium around 130 and don't go above that, there is no risk to fast correction. These are in their own words. The truth, as one would expect, is sort of somewhere in between, and we have to admit that perhaps a lot of it is unknown. So I'll take you through the timeline. Central pontine myelinolysis, or CPM, as we know it, was first described in 1959. It wasn't until 18 years after that that the first association of sodium itself with CPM was described. And it took another 10 years before we really associated overcorrection or fast correction with CPM. And it was about this particular time that, we kind of went from CPM and coined this term ODS, or osmotic demyelination syndrome, because we thought that this disease, CPM, was primarily caused by correction of sodium. And then, of course, you had the 1990s, which I termed the battle because there was a lot of debates on sodium, correction, its relation to CPM, what should the right correction rate should be, and so on and so forth. And then 25 years after that, we kind of, started practicing the way we do now. And that led to some guidelines, unofficial in the US, more official in Europe, because it was made by the Critical Care Association, the European Renal Association, and the Endocrine Society. And then after these couple of new studies that have come in, have they changed our understanding, or does the controversy still continue? I think that's going to be part of the discussion today. So that's the rough timeline. So we'll go back and started where the story first began, 1959. It was the time that Fidel Castro became the prime minister of Cuba, and he was prime minister till 2008. It was also the time that Sleeping Beauty, the very first 70 film, came out with stereophonic sound, and audiences were amazed at the time of the quality of the sound in the picture. Right at the same time that this was happening, there was a couple of scientists in the neurology unit at the place where I practice, MGH or Mass General in Boston. They were really studying the effects of alcohol on the brain. And they described this syndrome called central pontine myelinolysis, which they thought was distinct from anything else that had been described at that time. So they named it CPM, a hitherto undescribed disease occurring in alcoholic and malnourished patients. So what did they actually find or describe? They described 4 patients. 3 of them had severe alcoholism in their history, and 1 was severely malnourished. They described a neurological syndrome of rapidly evolving quadriplegia, along with weakness of the face and the tongue, which we term as pseudobulbar palsy. Strikingly, when they looked at the autopsy and the brains of these patients, they found that they had sharply demarcated symmetric demyelination in the pons, but the nerve cells in the axis cylinders were well preserved, which is not what you see in a lot of other neurological diseases. This was very distinct pathology. It's not nutritional, not vascular, not traumatic as they'd seen it before. First, they thought perhaps it was infection because a couple of cases were described in association with certain infections, such as TB. Then they thought it was some toxin. How about ischemia, vitamin deficiencies, liver disease? As more and more cases came about, all of these other sort of associations came about. The other one that's, what was very importantly described was osmolar changes. It was described in this patient with DKA, where the sodium was never low, but went from 140 to around 170 and came back all the way down during the treatment of DKA. And they thought perhaps all these osmolar changes that happened with the glucose and the sodium was what led to this syndrome called CPM. But throughout history, while they were describing this, 2 things stood out quite clearly. One was alcoholism, and the other word was malnourished, because a lot of these patients had history of severe alcoholism and malnourishment. So Rosman, one of the physicians who was treating pediatric patients at that time, he saw a case of CPM in a pediatric leukemic patient. And he was like, I really want to find the cause of this. I didn't think this was a pediatric disease, so why is this happening? So he started to look at the risk factors for CPM. He looked at all the cases that were described to date until 1966. And he thought, alcoholism and malnutrition stood out, as we've spoken about. Almost all the cases, except 7 of them, had either alcoholism or malnutrition that was significant. He also thought he'd look at electrolyte imbalance. In those days, hyponatremia was chiefly described as dehydration. So he wanted to see if perhaps there was electrolyte derangements that could lead to this disease. It was sort of hit and miss. Half of the cases didn't have anything. Some cases had some electrolyte imbalance, some cases described as having dehydration or hyponatremia, but there wasn't a clear association that you could see at that time. So we move on to 1967. So far, quite a few cases have been described, but no clear association except for alcoholism and malnourishment. 1967 was, called as a long, hot summer of 1967. The Civil Rights Act had just come out in 1964. And this whole summer, there was a period of racial unrest because of the social inequalities of that time and the period of having to adjust to new civil rights that had been, sort of widely been promoted and implemented. At that time, as you can see in medical literature, we use terms that are very different. So while describing this study from McCormick, I sort of put the racial classification up there just to see how far we've come in describing our patients with respect to many other things. So McCormick described 3 patients with CPM, but again, like Rosman, they wanted to go back and see the association of CPM with diseases. They did it in a much more detailed fashion. They described each case in very detailed descriptive characteristics. If you look at the paper, it's very well described. So they described 69 patients with CPM, and they found the same associations. 50% had severe alcoholism, 77% were malnourished, and 20% had neurological disease. They also looked at severe electrolyte derangements such as hypokalemia, hyperkalemia, hyperglycemia, and dehydration, which I assume is hyponatremia, and they found that that was present in 33% of patients. So here was a conclusion from McCormick, which was that the wide spectrum of disorders from which patients with CPM have died suggests the possibility that there may not be one, but several causes, the end result being the pontine myelinolytic lesion we now know as central pontine myelinolysis. So far, so good. We've described a new disease. We've sort of tried to understand the risk factors for the disease, and a variety of risk factors have been described, and we've honed in on maybe 2 or 3 of these risk factors, right? 1977 comes rolling along. It was the time that Apple produced their first personal computer, the Apple II. Rocky was the Academy Award winner in 1977. And at the same time, you had this important paper from Burkhardt. He really wanted to look at the association of CPM and sodium. This was the very first paper that sort of described what happened to the sodium in these patients. So he took 46 patients with CPM who had their sodiums published, and he saw that around 25% had a sodium that was, what we describe as severe hyponatremia. 13% had completely normal sodium, greater than 135. The vast majority, 2/3 of the patients, had sodiums in between 120 and 135. So 75% of patients in this study with CPM had normal sodium or mild to moderate hyponatremia. Of course, there was very clear, hypothesis as to why sodium was so important, right? Like it made sense that, to prevent sort of swelling in the brain in chronic hyponatremia, you would extrude these electrolytes. So when you did try to correct it, then you have more shrinkage of the brain. So they did a variety of animal experiments to sort of prove this hypothesis. Majority of the time, the animals were subjected to 2 to 6 days of hyponatremia. A lot of water was given, DDAVP was given, and then they would normalize the sodium, which at various correction rates between 15 and 30, either by like giving them normal saline or sort of letting them autocorrect, or trying to prevent them from autocorrecting by giving them more water. And then these different groups of animals, they would autopsy them and study to see which group had the most demyelinating lesions. And there was definitely a clear association between those who had self-corrected or corrected fast and the demyelinating lesions that you see. Except the lesions were not just in the pons in many of these animals. They were extrapontine. They were not exactly fitting like you see in the human specimens, but they were somewhat consistent that the faster you correct, or when you correct at these rates of 15 to 30, you do have some demyelinating lesions. And these studies were done not just in rats and mice, but also like rabbits and dogs. But the question always remained, is demyelination because of the fast correction, or was it because of overcorrection that you corrected to almost like normal or high sodium levels, and maybe you should not be doing that? 1987 comes rolling around. This was the time of the pivotal Rick Stearns paper that was published. And it was also the time that Ronald Reagan gave his famous "Stand on this wall" speech about the Berlin Wall. The Berlin Wall, of course, didn't come down until a couple of years after this, but it sort of set the tone that after the wall came down, this speech was hailed as important. Similarly, before Rick Stearns' 1987 paper came out, a year earlier, the seeds were already sown because now they named CPM as osmotic demyelination syndrome, and an important paper was published in the NEJM where they looked at patients with severe hyponatremia who had neurological sequelae. So when they said neurological sequelae, it wasn't just radiological or autopsy findings of CPM, which was only present in these 3 out of 8 patients, that it could be any neurological sequelae. They could be in a coma, they could have weakness of the legs or arms, so on and so forth. So they said they found 8 patients in whom they thought that the overcorrection or correction of the sodium actually led to this syndrome called osmotic demyelination syndrome. And then they compared that with everybody else who'd come before. These are historical cases where they could get their hands on about sodium levels and what the correction would have been. And they sort of divided them into those who had neurological complications and those who didn't. And they found that, in those who did have neurological complications, the rate of correction was pretty high, whereas in those who did not have neurological complications, the rate of correction is definitely lower than 12 per 24 hours. And if you corrected more than that, your chances of ODS was much higher. And this sort of, was the thing moving forward. Everybody sort of adhered to this thing that CPM or the radiological lesion did not need to be just that we have this syndrome called osmotic demyelination syndrome, which is clinical. And so you did not have to have proof of a CT finding, an MRI finding, or something on the autopsy. And this is seen in all the other studies, retrospective studies that were done through the years. So the pivotal seminal study in 1987, this was the first time that we did not start with CPM. We start with hyponatremia. So 62 patients with a sodium of less than or equal to 110 from the same hospital in Rochester, New York. And they found that 7 of them had this syndrome called osmotic demyelination syndrome. Again, did not have to be radiologically proven, but just that, they had these severe neurological complications. And then they saw what the starting sodium was, what the correction rates was, how did these people recover, so on and so forth. The ODS incidence in that cohort, as I mentioned, was in 7 patients, so around an incidence of around 11%. Even in that cohort, 2 out of 7 patients, while they did have neurological complications, they did have ultimate good recovery. So 1987 was the point at which ODS was no longer a radiological or autopsy-proven disease. It also established sodium as a centerpiece risk factor for ODS. We no longer studied CPM and tried to find the risk factors. We went from sodium and trying to see if we could prevent neurological complications by playing with the correction rates. This was also the paper where 12 was named as a number above which you had more complications than not. And that if you corrected faster than that, perhaps your risk of ODS was higher. And how do they know that? Well, I point you to this very nice chi-square table at that time that was done with other risk factors such as alcohol, and they proved that the correction rate of greater than 0.55 millimole per liter per hour, which roughly translates to around 12 in the first day, was the only one risk factor that was significant in the chi-square table. And this was the conclusions of the author, which I think is very important to read in its originality. They said, thus, the neurological complications in our patients were probably the result of well-intentioned efforts to correct a relatively benign condition rapidly. That is, we suggest that osmotic demyelination syndrome is an iatrogenic disease. Now, the way that this is framed, wasn't really controversial at that time, but has since been found very controversial just because of the medical legal implications of such a statement. At the same time, and in the same journal in 1987, there was another paper by the Targaryen group that they basically said, hey, there's this new term called, we were studying central pontine melanolysis, and now we are apparently grouping them all together into this thing called ODS. We should be studying it in more detail because that's not been sort of our experience. They tried to rename it central demyelinating lesions, but that never sort of, caught on. So they studied 3 groups. They took everyone who was referred to them with a sodium of less than 120 who had undergone a CT scan. So this is their patients who had low sodium and basically imaging. Group 2 was a case series of patients with what they thought was CPM. They had radiologically confirmed or autopsy proven CPM. This is also in their center. Now, group 3 was patients who were described to have CPM and low sodium in literature. This is a historical cohort that they could get their hands on in terms of, who had well-described sodiums and had CPM. So what did they find? They found that in the patients referred to them, where the mean 24-hour correction rate was around 20, this was a small cohort, of course, but they had no cases of CPM. And in the cases of CPM that they had, they found that, hey, 4 of them had completely almost normal sodiums. In the rest, in the 8 patients who had CPM, the mean 24-hour correction rate, if their starting sodium was less than 130, was around 20. But importantly, all of these patients with CPM were comatose, or most of them had like severe neurological complications even before therapy initiation. They're saying that they were like admitted sort of with this disease, and this disease did not come on because of any treatment. And when they looked at the literature, they were like, okay, there's a few cases that have been described, and the rate of correction is around 15 to 20. So perhaps at very large correction rates, there may be an association. So their conclusion was this: rapid correction to mildly hyponatremic levels is not associated with either clinical or anatomic evidence of neurological damage. Of course, when you get differing conclusions from two groups of very smart, established scientists, there's a lot of controversy and a lot of debate. And if you want to, go into a very nerdy conversation, I suggest reading this paper, which is Treating Hyponatremia, Damned If We Do and Damned If We Don't, where sort of they delve into the physiology of, correction and how things go in hyponatremia and how patients respond. But there's no conclusions from this paper. But that's kind of the sort of the field that you had in the nephrology field in the 90s, where you had these differing conclusions, but perhaps it's easier to practice medicine in a way that's more defensive and not like have to commit, because there was some clear evidence that maybe correcting fast had these neurological complications. I do want to point out the one other prospective study that was done at this time that is often forgotten, by Brunner, where they took like patients with sodium of less than 115. There were only 13 patients in the study, and what they did was they did serial MRIs at 2 weeks. That's not 2 weeks, that's like, I think, 4 to 8 weeks, and then 12 weeks, where they looked to see if patients had any neurological issues. And they did find 3 patients with CPM that was radiologically confirmed. All these patients recovered neurologically, but again, with very high correction rates, 25 in this particular study, they did find that the rate of CPM was higher. So we come to the 1990s, and this is when the controversy or some of the debate really takes off and becomes a little ugly. So there's 2 papers published with the Targaryen group in the 1990s. The first one is in 1992. This was the year that Bill Clinton was elected president. Malcolm X, the famous Spike Lee movie, came in, and Mae Jemison was the first African American woman in space. So a lot of historical, legendary things happened. At the same time, this paper was published, where the authors looked at 65 patients with post-operative encephalopathy and low sodium. So basically, patients with severe hyponatremia and post-operative encephalopathy. They said out of those patients, more than half of them either died or had permanent brain damage. So a very high rate of neurological complications in patients with post-operative hyponatremia. And they also said, and I don't know the reason for this, that out of those, 33 were female and 25 of them were menstruant females. And till date, I haven't really found a satisfying explanation as to why, menstruant females in particular would be at high risk. Females, I sort of get because of the low body mass and the different characteristics of the volume compartments. And they said that, the cause of death in the majority of these patients was respiratory arrest. So if you have patients with severe hyponatremia and you don't treat it as fast as you should, perhaps you expose yourself to this risk that it could cause respiratory arrest. 1999, they did another study, this time with 53 female patients with post-operative hyponatremia. These were postmenopausal women who are traditionally considered at high risk for hyponatremia after surgery. And they basically divided them into 3 groups. They said they were going to intervene early with early NaCl. Some groups got late NaCl, which is, didn't get intervention for a certain amount of time and then got NaCl. And the third group hardly got any intervention except fluid restriction. So they were not really corrected that much. And this is sort of like, it's not really a prospective study, it's more a retrospective study, and they're looking at what therapies were implemented in different groups of patients. And their conclusion was rapid correction saves you from respiratory arrest or hypoxic events. That if they did correct using saline early enough, then your rate of respiratory arrest or death was much lower. Whereas if you just let them ride and not correct it, then it was, much higher. And slow correction was associated with a high rate of death. Now, as you can imagine, this obviously leads to controversy, right? Like you have a group saying if you correct really fast, you are prone to neurological complications. Now you have data coming out in these prestigious journals such as JAMA, which says, hey, in these groups of patients with severe hyponatremia, if you don't correct them, then you're exposing them to respiratory arrest or death. And there's a lot of words. So I'm not going to paraphrase at all. I'm just going to read exactly what the authors wrote to each other. This was a letter to the editor by House of Stark. They said, in the past 15 years, Dr. Targaryen and Dr. Targaryen's colleague have reported more than 200 such patients referred to them after respiratory arrest or hypoxic event. The authors apparently played no role in the management of these cases. During the same period, the authors directed the treatment of 49 patients with symptomatic hyponatremia. No patient developed a respiratory arrest or hypoxic event, and all recovered without sequelae. Apparently, to be treated for hyponatremia by the authors guarantees protection from hypoxia before treatment and brain damage after it. To be treated by anyone else risks almost certain respiratory arrest, death, or disability. The invariable occurrence of pre-treatment respiratory arrest and mechanical ventilation and the high incidence of fatal cerebral edema in patients purported to have chronic hyponatremia fly in the face of 25 years of accumulated physiologic knowledge and clinical experience, some of it contributed by the Targaryens themselves. Somewhat of a low blow, but there was a response by the authors for this, which was that Dr. Stark's emotionally charged comments may have limited their ability to critically review the issue of therapy of hyponatremic encephalopathy. Dr. Stark is a longtime advocate of therapeutic nihilism in the management of hyponatremic patients. He appears to suggest that only patients treated under our guidance can have successful outcomes, whereas to be treated by anyone else risks cerebral edema, respiratory arrest, and death. Apparently, Dr. Stark has either neglected to review the literature or selectively avoided all evidence to the contrary. Dr. Starr's contention concerning the rate of correction remains unsupported by data. Now, before we move on, I have to say this is in the public realm, right? This is actually published in JAMA. And so you can imagine what the conversations were behind the scenes. And I've spoken to some of our senior colleagues regarding, what the conversation was. And it's as polarized as you can imagine it might have been. But this is the way we practice since then. Before the 1980s, our average correction rates for patients with severe hyponatremia was more than 12. And slowly, there's been some fluctuation, but slowly but surely, the average correction rate is definitely down compared to before, definitely lower than it had been by at least 3 or 4 points compared to before. And this is data from our hospital over 25 years. Each year has around 200 to 300 patients. And we definitely see that there is a trend towards lower correction rates. And of course, that kind of became in vogue, right? Like we correct slowly, we try to do it as slowly as possible. And over the years, that's been our practice. And in 2014, it became even more written into our practice when the guidelines, so-called guidelines, came out. Now, the USA guidelines are not really guidelines. They're basically expert opinion by a group of 7 nephrologists, whereas the European one, as I mentioned before, is from various societies. The USA places a clear target, meaning they say 4 to 8 in low risk, 4 to 6 in high risk. They also limit it to 8 in high risk and 10 in low risk. Whereas in the European guidelines, all it says is, hey, try to limit it to 10 if you can. But both of them do say that if you do exceed the limit, then you should consider relowering when these limits are exceeded. And that data is probably the weakest of all. But anyway, so that's where we stand as of 2014. And that's kind of where we stood for the next 10 years, right? But in practice, all of us have observed that, despite us trying to classify into low risk and high risk, when they say high risk, they mean patients with alcoholism, malnutrition, hypokalemia, etc. That's not how we practice, though. we kind of like everybody with severe hyponatremia gets placed in high risk protocol, and we kind of use the same protocol. There's a lot of delay in the use of 3%. This was even related to the, that some institutions would only give 3% with central lines. Some institutions still do that. But even after we move to peripheral lines, there's still a lot of hesitancy in using 3% saline and correcting the sodium quick. There's, of course, a ton of ICU transfers because, we deem these patients very high risk for neurological complications. So almost every patient with low sodium gets to go to the ICU. This is also important for monitoring because it's very hard to monitor patients Q3 or Q4 outside the ICUs. And of course, we suspected that this may have led to long hospital stays. We don't know that for sure until the new studies came out, but that was one of the suspicions. And as I said before, litigation is a big part. Millions and millions of dollars have been paid out in one way or the other because of correction rates and the impact that they've had on specific patients. So what happened in the last year? Well, we sort of jig this controversy after like 30 years of no data or very little data. And two, studies came out. Fast correction, which was kind of like, not in the work and was waiting on the sidelines, got a little bit of a perk, a little bit of a jump start with these two new studies. But the evidence I would caution you is not, really supportive of fast correction per se, but sort of wants to make you think, basically. So the first study by Macmillan, this was a Canadian cohort of almost 23,000 hospitalizations. It's important to note that this study's threshold was less than 130. So only around 12% of patients had a sodium of less than 120. The majority were between 120 and 130, which you could argue is important because the majority of CPM occurs in that group between 120 and 130, right? But even among the 23,000 hospitalizations, all they found was only 12 cases of ODS. This was the entirety of Canada in 5 academic hospitals, like a very large population. And also importantly, out of those 12 patients, 7 did not have rapid correction, which was defined as more than 8. However, as like in many other studies, as we suspect, a lot of patients do correct fast, regardless of what you try to do, right? So even in this cohort, 18% of patients, or in 3,600 admissions, there was a lot of fast correction. However, like very few patients in that cohort actually had ODS. The associated risk factors that they described was very similar: alcohol use, malnutrition, liver disease, hypokalemia, cancer, all been described 30, 40 years ago that kind of stood. The second study was from our own hospitals, the MGH and the Brigham, where we looked at around 3,200 patients with severe hyponatremia. This is all sodium of less than 120, which was described as the highest risk in all the guidelines in terms of correcting fast and ending up with ODS. We sort of divided it into 3 groups because we felt like if you compare the US and Europe, that most people were correcting between 6 and 10. So we needed to keep that as a reference group. And we looked at a group less than 6 and then greater than 10. And as you can imagine, even in our cohort, in this group of patients with severe hyponatremia, like no matter what you do, and we've been practicing within the realms that 6 to 10 is probably the way to go, that 1/3 of our patients, 30 to 40% of our patients are going to correct fast no matter what we do. So what did we find? Our intent was to actually study the effect of correction rates on 2 things. One was mortality, and we definitely found an association between slower correction and increased mortality. However, we split the data, adjusted the data for severity of disease, that kind of stayed the same even in subgroups or propensity score analysis. And importantly, if you had a low correction rate that was associated with is associated with a longer length of stay by around 2 to 2.5 days, which I think is crucial. Now, I'm not the kind of person who's prescribed to this thing that, hey, if you stay longer in the hospital, your risk of like medical errors or like risk of catching a lot of other things is high. I think that particular data is pretty messy, but we can all agree that the costs that come with increased hospital stay is significant, especially in the current modern realm. What did we find with respect to CPM? So we found only around 7 cases out of the 3,000. In a 25-year cohort, we only had 7 cases of CPM. And interestingly, in our cohort, 5 out of 7 patients had a sodium correction rate, which was like less than or equal to 8. And we had the same risk factors that's been described with other cases of CPM, such as alcoholism, malnutrition, hypokalemia, hypophosphatemia, etc. So the two NEJM evidence papers I think are quite important, but I don't want to ignore the other paper that I feel is also as important, which is a George paper from the Geisinger system that came out a few years ago. Their intent was to study the risk factors for overcorrection and CPM, and in their 1,500 patient cohort, they had 8 patients with CPM, out of whom 7 corrected fast. Their fast was 8, so you had a couple of patients at 8, 9, and 10. So but they definitely did find an association between fast correction and CPM, though the incidence of ODS or CPM itself in all 3 of these cohorts were extremely low compared to like the historically described incidences, which were as high as 10 to 25%. All these cohorts had a rate of like less than 0.1%. And if you look at the outcomes, that was also, if you look at the historical outcomes and compare it to now, they were not a whole lot different, but definitely different in terms of mortality and severe neurological complications. The 2 papers that had neurological outcomes described are our paper as well as a George paper. And pretty much everybody, except a couple of patients, were lost to follow up. Everybody else had partial or complete recovery neurologically within a few months after hospitalization. So, definitely not the full-on, extremely high morbidity mortality cohort that was described in the 80s and the 90s. However, we do practice in a different realm of correction rates. I want to caution you about that. And we've all seen these cases where, there's been a ton of cases published on like, hey, we corrected normally or we corrected slowly. How slow is safe? Because despite what we do, we did see CPM in our patients. And there's been a slew of case reports publishing that. There was even an NEJM clinical images in medicine that was published. And in this particular patient, the correction rate was actually like 3 per 24 hours and very, very slowly corrected. And despite that, this patient had CPM. And somehow we did this ourselves too, and there was another neurological study that came out that went the other way, not starting with sodium, but starting with CPM and looking at risk factors and seeing if anything had changed. So in this almost like 20-year period, Fitz et al., this is again an MGH and a Brigham cohort, they found 45 cases of confirmed CPM or ODS by either CT or autopsy, and they found that 75% of the patients with CPM didn't even have significant hyponatremia. The sodium was greater than 130 in 3/4 of this cohort. 57% of the cohort had, the risk factors that were described originally, which is like alcoholism and malnutrition. And importantly, 60% made a full recovery. 16% had death, but that death was due to like things like liver failure, alcoholism, kidney failure, cancer. So these are not really neurological deaths that you would associate with CPM. So why does it happen? Like, there should be some sort of a theory as to like why patients with alcoholism, malnutrition, they're under such heavy risk for any small changes, whether osmolar changes or other changes that happen. And the most conclusive part is a couple of papers that were published, which looked at like apoptotic markers in patients with CPM and these brains. And the hypothesis is probably this, that the glial cells, in order to prevent shrinking or in order to protect them from osmolar changes, they need to really like import electrolytes or export electrolytes using the NAK ATPase pump. So they really need to do that in order to sort of preserve their shape and their structure. And this is an energy dependent or energy heavy process, use a lot of energy. And that energy you don't really have in patients with alcoholism and malnutrition. And that leads to an apoptotic process where you have release of glutamate from the energy starved neurons. And that itself can lead to further damage because mitochondria are working at really high workloads and they release a lot of free radicals, and the glutamate and the free radicals, all of this can be very damaging and can cause demyelination in the sharp demarcating way that we see in these patients. So I think in a way, when it comes to conclusion of risk factors, I do think the factors such as alcoholism and malnutrition may be the main predisposing conditions underlying CPM, while others such as osmolar changes, including sodium changes, may be the straw that breaks the camel's back. You can't say that there's no association between correction rates and CPM based on the data that we have. All we can say is, sometimes it just happens no matter what you try to do. And the controversy has predominantly been directed at sort of the methodology of the new studies, though, as you've seen, I have pointed to the methodology or sort of the limitations of the old studies, which kind of define the way we practice. So compared to them, I think the new studies are much more robust in terms of the sample sizes and the way that we study statistics. However, you can never correct for like severity of disease in a very true manner. So unless we get an RCT, it's going to be very hard to define if one group is better than the other. And I don't think there's ever going to be an RCT given how low the incidence is. And again, I want to point to two things here, that the incidence in these new studies, when you take all these patients together, incidence is so low compared to what we saw before. And also the neurological recovery in this majority of patients is pretty high in those patients who get CPM in the current era that we know of. And there's been some, a lot of thinking behind like how to move the field forward. One of the things published in the CJSON editorial, which was Stay the Course, was a multi-center chart review. I have a lot of skepticism about that because the way, we write on Epic nowadays, you have these intubated, sedated patients, and we say they're like alert and oriented times 3 in our chart. It's just all automated. So I think it's going to be very hard to glean good data out of Epic in the Epic era to study these patients with neurological complications without. And of course, there's been some consistent statements and papers published, but again, it's all about putting things in perspective. And I think there's definitely two camps here, and there's nobody really putting things into perspective in the middle. And I'm hoping that the conversation can move forward as to the limitations of the data that we have, what's the best way to do things, not just what the safe way to do things is, what would give us the best sort of like bang for our buck in sort of treating these patients and preventing side effects, but also not using our resources as much in trying to like treat these patients in a very close monitored manner. And I'll end with this, which is that, the new data questions established practice. It's really designed to raise questions and not provide all the answers. And all I'll say is I'm once again asking us to look at all of the evidence and not just like criticize one piece of evidence and put them against each other. And when I look at the history, I think it's kind of filled with like, different sorts of pieces of data, which all kind of help the field move forward, but doesn't really give us a definitive answer as to like how we should practice. But having talked about this, I don't want to end the talk in a wishy-washy sort of manner. So I do want to sort of put my money where my mouth is and kind of tell you what I really think about this. Which is that I think with CPM and ODS, I think it's very clear. I think it's a black and white diagnosis. The incidence, though, is extremely low. It's only like 0.1 to 0.2%. The prognosis is, if not great, I think it's fair. Meaning, I think a lot of people recover. I think the few people who don't, we haven't seen many of those patients in the last 20, 30 years. But again, we are practicing in a world where we treat everybody to a correction rate of 6 to 10, and we don't try to go higher. So maybe that's why. But clinical ODS, I'm really suspicious of in terms of the definition of it, because it's no clear definition. Does it mean that if you don't have imaging findings, it's lower severity? It's been suggested that sometimes imaging findings happen 3 months, 6 months after. I'm like, if that was the case, how do you know that it was the hyponatremia correction event that led to this diagnosis and not just the underlying factors, as has been noted in many other patients, even without hyponatremia? And this is known for now, like radiological CPM, that CPM as a disease primarily occurs in non-hyponatremic states. So maybe we nephrologists are not as important in trying to prevent this disease as we think of. So I think we should be a little humble and kind of say that we don't know a lot about what happens in this disease, and maybe sodium is just one of many risk factors. What about correction rates? I do think, with very high correction rates, and we haven't done this in a long time, I think there would be a mistake. Like, I don't think I would go for anything like 15 to 20. But at the same time, in these patients who are so predisposed to neurological complications, I really doubt a correction rate of 3 versus 6 versus 9 makes a big difference. If somebody tells me a patient with CPM had a correction rate of 9, do I really think that if they'd gone slower at like 8 or 7 or 6, they may have prevented the CPM? I think that's a very, very big argument to make. That's the kind of argument that's made in the court with these litigations. And I think as a field, it does a disservice to a lot of doctors who just try to do their best, but overshoot by a little bit. And honestly, I don't think that's the reason why patients have CPM. They're just so predisposed to it. You could have gone at a correction rate of 3 or 4, and you could still have had CPM in those patients. My practice has been to go slow. I'm not advocating for large, high increases in correction, because I do think, especially in high risk patients with alcoholism, malnutrition, you have to be very careful because they're so predisposed. Having said that, I think in all others who do not have these traditional risk factors, if I don't think the data supports if 6 versus 8 versus 12 versus 15 makes a big difference. My approach has been to be non-lackadaisical. All I want to do is actually correct the sodium. I just don't let the patient just lie there at a particular sodium. I want to make an effort to correct it, and I try to do that the best I can. And do I bring it back down? Yes, I do think if you reach those correction rates of 15 to 20 in high risk patients, you should really, really consider bringing it back down to at least below 12. However, I don't think it really supports it if you go, if you have a goal of 10 and it reaches 11, do you really bring it down to 3 or 4 and then, have to start back again, which is what happens in a lot of cases. I don't think there's a lot of data to support that, but I would think about bringing it back down in very high risk patients. In all other patients, I don't think there's a big, push towards bringing it back down. If somebody corrects by 12 or 13 and they don't have any high risk factors, is there enough data to suggest that in this very, very extremely rare complication that, if you bring it back down, it's not going to happen? I think that'd be a really hard call, and I don't think there's much data to support that. I'll end with this. I think my ardent wish for this field is that experts move beyond taking sides, engage in meaningful research and conversation, importantly, to deepen our understanding of the problem, because I don't think there's going to be there's going to be convincing data to suggest one way or the other in this particular field anytime soon. But there is going to be data in the future. We just have to have perspective as to how to interpret that data and how to use that to help our patients. So thank you for the invitation, and thank you for the opportunity and the time.
Thanks so much, Harish. I mean, that was really good. It was a story. Made a difficult topic a lot more enjoyable, I think. And thanks for taking time to share with us. I had a quick question. In your recent study, I assume the data would be from more recently treated patients. Any difference with using DDAVP clamp or anything like that with incidence of ODS or anything like that, or no data available? Or...
Yeah, not really. I have to say, one of the things I was surprised about when we look at all the data put together is that the rate of hypertonic use in the first 24 hours has been so low in the last 25 years. Our data show that only 12% of patients even had hypertonic given. These are patients with sodium of less than 120, and we hardly use hypertonic in the first 24 hours after they get admitted, which I think is, stunning to me, meaning I just assumed that number would be really high, which just means that we are so, worried about correction and the ED and the residents are, that by the time they come to us, many patients don't even receive hypertonic. Now, DDAVP is the same. Out of the whole cohort, only like 3% use DDAVP. So I don't think it's as prevalent as we think it is. I think it's used after nephrology's call, which is after the first 24 hours. But in our cohort of like 7 ODS patients, some had it, some had DDAVP, some didn't, some got reloaded, some didn't. I don't think it really mattered. There's no association. And I try to look back in other cohorts as well, and there's not much.
Perfect. Thank you so much.